It began with a meeting that the department sponsored for Dr. Eyler to go to the meeting to deal with this issue of unconscious bias, which is a somewhat ineffable concept, but one that is very real and is very, very prominent in our daily activities. So I know that we have a full schedule, and Lisa, I will not delay.
Thank you so much, Dr. Joe. And thank all of you for coming today. I'm really glad to see such a big turnout for this topic. I'm really excited and pumped to talk to you guys about these ideas. And I want to start off by just acknowledging people who've been instrumental in making this possible. First, Dr. Judd for supporting the Diversity Committee and the idea of this workshop. Then all the members of the Chair's Advisory Committee on Diversity Issues, who are all extremely dedicated, very helpful, very thoughtful people. And I want to specifically thank Dean Atchison, Neil Doran, Tiffany Greenwood, Arpi Manassian, Don Sheezer, Monica Ulabari, and Jared Young, who made specific contributions to this workshop and to what you're going to see today. I'd also like to thank Paula and Christina from the Chair's office for all their help organizing the room, the food, the handouts. I'd also like to acknowledge the support of the department vice chairs who helped to send me, as Dr. Judd mentioned, to the Cook-Ross Unconscious Bias Learning Lab, where I was exposed for the first time to some of the ideas that I'm going to be presenting to you today. So just as a reminder, this is not my area of work, my area of expertise, but something that I've come to, just as I hope you will come to understand, may be very important for departmental and professional success. So today's outline, we're going to start by talking about what the goal is. What are we trying to accomplish, and how will this workshop get us closer to that goal? Secondly, we'll talk about what unconscious bias is, the definition, how do we measure it, where does bias come from, and then talk a little bit about the research that's out there on unconscious bias, what kind of role it's likely to play in academic medicine, and then spend a bit of time talking about how we might be able to minimize the negative consequences of unconscious bias within our professional lives and perhaps within our personal lives. And then I'll leave you at the end with some take-home messages and really some take-home charges, some calls to action, if you will, at the very end. And I want to say at the outset that we developed this workshop with a clinician scientist audience in mind. And so on the one hand, we're going to be presenting a lot of data, a lot of numbers, a lot of research studies, because there actually is a lot of empirical support for the topics that we're going to be covering. But on the other hand, we're hoping that you will approach this workshop a little bit more with your clinician's hat on, in the sense of how you would approach a new patient who's describing to you a lot of different information about their lives, about the problems that they're having. And I hope that you will take that information and think about it in a problem-solving way. How can I use the information that I learned today to make a plan of action to move forward? And also, like any good therapist, I hope that you'll be able to reflect and observe on your own reactions to this material. Countertransference, if you will. How am I responding to the information that I'm hearing here? And use that to help as you plan action in the future. So I hope you'll be open and curious as you approach this information. The goals of the Diversity Committee are really to improve, equity, inclusion, and cultural competence. Equity means treating everybody fairly. Inclusion means making sure that people feel welcomed. And cultural competence means understanding different cultural backgrounds and where people are coming from enough to be able to interact with them and to help to facilitate the interactions that we have. Why is this important? Well, this is important because the demographics of this country and of this state are changing rapidly. More diverse students will be coming our way. More diverse patients will be coming our way. And we need to be prepared for this demographic shift. In addition, it turns out that focusing on equity, inclusion, and cultural competence really aligns with our departmental goals. Our departmental goals are to have excellence in teaching, in research, and in clinical service. And research has shown that diversity helps with all of these things. Studies have shown that if treatment teams are more diverse, this is associated with better subjective and objective outcomes. Patients are more satisfied, and symptoms are more greatly reduced when there are diverse treatment teams. Diverse teams in terms of, let's say, a scientific team. A lot of us are doing team-based science now. It's the way that science is moving in the future. And as we construct those teams, we want to think about, is diversity something that will help with the success of those teams? And it turns out that research shows that diverse teams, when they're asked to brainstorm, generate more effective and more feasible solutions than less diverse, more homogeneous groups do. And students who are exposed to more diverse environments develop better critical thinking skills. So for all these reasons, for reasons having to do with clinical care, with teaching, and with research, it's important to focus and improve as much as we can the equity, inclusiveness, and cultural competence of our department. So how are we doing so far? Well, unfortunately, I think the answer is we're not there yet. So here are just a few facts and numbers to consider. In academic medicine, 6% of the faculty are from underrepresented minority groups, whereas these same groups make up about 26% of the general population. And when minority medical school faculty are asked to reflect on their climate, they're less satisfied with their careers and more likely to consider leaving academic medicine. In terms of female faculty, we've made great strides. There's a lot more female faculty out there in academic medicine, but still only 13% of chairs of academic medical school departments and 13% of deans are women. And male and white medical school faculty have been shown to be more likely to be promoted regardless of their department, their degree, or their NIH success. In fact, speaking of NIH success, a 2011 study showed that the success rate for getting R01s was 13.2% less for African Americans than it was for white applicants. How about the inclusiveness for disabled faculty? Well, unfortunately, there's not a lot of good numerical data out there about disability in academic medicine, but many disabled faculty report that medical schools are pretty disinterested in their issues and unsupportive, and they also report that they have to work harder than their peers in order to be recognized. And when lesbian, gay, bisexual, and transgendered medical students were asked about the environment in medical school in a 2005-06 nationwide survey, a full 17% of them reported a hostile environment towards them. So I think we have a long way to go. But you might say, well, that's just it. It's going to take a while for changes in our culture to percolate through academic medicine. So we're on our way, and if we just wait long enough, perhaps we can get there. It's just a matter of time, and then those numbers will increase. But I think if we look beyond the numbers and look at some of the studies that people have done to look at the underlying potential causes of inequality, that is discriminatory behavior, we see that we're not there yet in this regard either. I want to tell you about 3 studies. In one, letters of recommendation that had been written for medical school faculty to support their promotion were anonymized and made so that you couldn't tell the gender of the person that the letter had been written about. And then they were rated by people that were blind to the gender of the faculty member. And when this was done, it turned out that letters that had been written on behalf of women were shorter, they raised more doubts, and they portrayed women as students and teachers, whereas men were characterized as researchers and professionals. Another study that was published just last year sent resumes to scientists, both male and female established scientists, with the idea that these were resumes of someone that were going to be applying for a lab manager position and wanted to get feedback on the nature of their resume. So the scientists were asked to judge these resumes on the competency of the candidate, how likely they would be to hire them, what starting salary they would give them, and how likable they were. And there were 2 resumes that were sent out. The content of them was identical, but one was about Jennifer and one was about John. So the only difference between these resumes was the name. And it turned out that both male and female faculty rated Jennifer's application as reflecting less competence. They were less likely to hire Jennifer, and they would offer her about $4,000 lower salary compared to John. Now, the good news, perhaps, was that Jennifer was rated as much more likable than John. So, and then the third study is one that was just recently published this year, and it examined the applications of people, psychology graduate students. And they were able to, they had information about the body mass index of these applicants. And when the applications were rated in terms of qualifications, and also the letters were examined for how many positive versus negative qualities were mentioned, what they found is that there was no relationship between body mass index and the qualifications of the candidates. And in fact, those with a higher body mass index had slightly more positive letters, and yet there was less, they were less likely to be accepted the higher the body mass index. Okay, so all of these show that in terms of the actual behavior that underlies the numbers that we talked about before, we still, again, have a ways to go. There are still inequities in the pipeline that's very important for academic medicine. What about treatment of patients? Well, this could be a whole lecture in and of itself, but I just want to mention some data here. And again, I think the take-home message is that we're not treating all of our patients equally. From 1991 to 2000, it's estimated that 176,000 deaths were averted due to medical advances, but that 886,000 lives could have been saved if we corrected healthcare disparities. Studies have shown that African Americans who present at the emergency department with bone fractures are less likely to be given pain medication than white patients. In another study where female and black patients were compared to white and male patients, and they presented the exact same symptoms of cardiac difficulties, fewer cardiac catheterizations were recommended for the female and black patients. In another study where patients were trained to give the exact same report of their knee pain to physicians, those 67% of men who reported these symptoms were recommended for knee replacement, whereas only 33% of women were recommended for knee replacement. And there are inequalities in healthcare for lesbian and bisexual women. Only 57% compared to 62% have received a mammogram in the last 2 years. And in our own field of mental health, a recent analysis of data from the Medical Expenditure Panel survey from 2005 to 2009 showed that whites were more likely to get adequate mental health care, which was defined as 4 or more visits. They were 6% more likely than blacks and 5% more likely than Latinos. So unfortunately, our treatment of patients is also showing some signs of inequality that have not normalized. But this is interesting in the context of what a lot of people feel is kind of a post-racial America. Many people feel that things are getting much, much better in terms of the overt prejudice that people are displaying. So this is really a paradox of persistent discriminatory behavior, persistent inequities in the face of rapidly declining overt prejudice. And of course, also in the face of many policies and laws that prohibit this kind of discrimination. So where is this disconnect? There are inequalities there, but things seem to be getting better when you look at how overt prejudice is changing in this country. In fact, in a meta-analysis that examined the relationship between explicit negative attitudes towards racial groups and the type of discriminatory behavior that I just talked about, the studies showed that on average there was only a correlation of about 0.12 between the degree of negative explicitly expressed attitudes and discriminatory behavior on these different manipulations. So it seems that overt prejudice is not the whole story. This is a little hard to swallow if you think about it, because our dominant cultural principles about decision-making for things like hiring, promotion, healthcare decision-making is that these things are under our conscious control. We decide what we're going to do by looking at the facts objectively. We have an accurate, objective view of the world, and then we make a rational and consistent decision. And this is how our legal system is set up, and it's how we really all feel about how our decisions are made. So if that's the case, then it must be that discrimination is really due to bad people who consciously and consistently make unfair decisions based on their view of the world, right? Unfortunately, the paradox suggests that this might not be the case, and there's mounting evidence that there's more automatic, unconscious factors which play a big and maybe even bigger role in everyday behavior. This book, very interesting. I highly recommend it to you if you're interested in further reading on this topic, by Mazrin Banaji and Anthony Greenwald, called Blind Spot. But I thought it was interesting the subtitle that they chose, Hidden Biases of Good People. A lot of diversity training in the past has kind of been focused on rooting out the bad eggs, figuring out those people that are going around and making conscious decisions in a way that's discriminatory. And what we would like to try to emphasize today is that good people, in fact all people, have these kind of hidden biases which influence our behavior. So what is unconscious bias? Well, bias has a negative connotation. The word bias has a negative connotation. But in fact, the way we're using it is in more of a cognitive psychological term that means a tendency that results in judgment without question. So this tendency can be either positive or it could be negative. That is, you can be biased towards something or you can be biased against it because it's just a tendency. And unconscious bias are associations that are without awareness, intention, or control. Now, unconscious bias, I would like to argue, is ubiquitous and it's also necessary. Brett Pelham said, being biased is how we get through life without evaluating afresh every time we experience it. Okay, humans, as we all know, are social animals. And it turns out that we need automatic processing. It allows us to rapidly determine friend from foe. It would be pretty difficult to survive in this world if every time somebody came up menacing you with a knife over your head, you said, I wonder if this person intends to do me harm. I mean, it could be, but perhaps they're just a Halloween costume, and they're, if we did that, you would be dead. So it's important for us to have these implicit, automatic, very rapid assessments of the danger of a situation. And it turns out that a lot of research suggests that we act first and then we reflect. So we actually act and behave based on these automatic and unconscious biases, and then we layer on top of that the reflective process that makes it feel like we made a conscious, rational decision. Okay? A lot of times, what seems like a conscious decision is actually a post hoc construction of a rationale for our automatic behavior. Where do these unconscious biases come from? Again, these biases toward things, biases against, these attitudes, how do they get built up? Well, most of the research suggests that they come from our experiences and our socialization. And I'd like you to consider, as you're thinking about what your own context is and what biases you might have, the types of experiences that you've had as an individual. Maybe you've been stigmatized. Maybe you've been traumatized. Maybe you've been rewarded for particular things that you do. Those experiences get encoded and schematized, and they're part of your implicit bias. Also, your experience is part of a group, the Department of Psychiatry. We have a shared history. We have shared beliefs. We have stories that we share. Those things are part of our context, and our unconscious bias comes in there, into play there. Our institution, whether it be UCSD or more general institutions like the institution of marriage, there are behavioral norms for how one behaves, and those things are encoded in our implicit attitudes. And then, of course, culture is a big one. The norms of our culture, the language, the values, the practices, all of these can are in there deep down inside. and self-related attitudes. It turns out that we're actually pretty egotistical when it comes to our automatic biases. We're very likely to prefer, feel more comfortable, have a bias towards things that are like us. And that leads to this phenomenon of in-group versus out-group. So we're going to put you to work a little bit right now, and I'm going to have Arpi Manassian come up and talk to you about this first exercise.
Okay, so in everybody's packet, you should have a very simple looking piece of paper that has a circle with the word me. Everybody see that?
It's in the packet under the blue.
Everybody got it? Okay. So grab a pencil or a pen, and we're not going to take too much time on this, and don't think too hard about it, but take a moment to list words on this piece of paper that describe facets of your identity, whatever comes to mind. And just sort of keep in the back of your mind the role of individual experiences, groups, institutions, culture. If you'd like, you can spatially group words according to relatedness, however you'd like to organize it. If you'd like, you can put an asterisk next to those parts of your identity that you think about daily or weekly in a frequent way. So just spend just a few minutes doing this. Like I said, don't think too much about it, and we'll chat about it in a couple moments. So discuss it a little bit. Anything that anybody noticed that you'd like to share with this large group of your peers? Yeah, Beth.
So I picked all adjectives,
Okay.
which was kind of surprising to me. When I kind of ran out of adjectives, I kind of peeked on random names. And they had picked roles. And
Okay.
I didn't go there.
Okay. So you picked more descriptors of yourself or things about you versus roles. Interesting. Okay, good. Anybody else? Yeah. Ron. Mm-hmm. Right, right. All the many roles that we all play. So, exactly. So take a look at your piece of paper and then reflect on the aspects of your identity that are most salient to you, whether that be more personality features or your roles, and think a little bit about how those might influence how you relate to other people. And then also kind of take a moment, I think this is relevant for many of us in this room, and how many of those words reflect your professional identity versus your personal identity. It's kind of a big deal for most of us. And then think about whether you listed any aspects that place you in the majority in sort of either ethnicity or institution, culture, that sort of thing. As it turns out, identity linked to minority characteristics seems to be more salient, and majority characteristics are often taken for granted. So aspects of your identity which may place you in some kind of a minority may sort of play a more salient role in the way you see yourself versus those things that sort of put you in the majority. Does that make sense? Yeah? Anybody notice any trends like that? Yeah. Okay, an example? Sure. Does anybody else want to come up with an example before I give one personal example? So, for example, somebody who might be of a minority ethnicity may place that on their, may be more likely to put that on their list versus somebody who is, say, of Caucasian background. So that's one kind of way that might manifest. Okay. Yeah.
I think that the personality of therapists
And so by personality, you mean sort of what they were more or less born with in a way, or their uh-huh, yeah. Good.
I think it'd be good for you to set a context for this. Because some people are putting down skills. Some people are focusing on their role within the university. And others are focusing on being people. Like my words are husband and father. And father to my children, but a father to my departmental family.
Right, and so I think we kept it purposely vague to see what comes up for people, because it is these things that end up being sort of the most salient features of who you are, how you see yourself in the world, and how you relate to other people. So, okay.
Thank you. And of course, what gets activated may depend on whether you're sitting in a big room of people talking about unconscious bias or whether you're introducing yourself to the PTA. You know, I think obviously makes a difference. But we wanted to give you a chance to just reflect a little bit about yourself, again, trying to keep this not just all about learning things from the outside, but also looking inward. Okay, so I'm going to turn now to describing some of the research on the influence of unconscious bias, but first I need to tell you a little bit more about how people in this field have measured unconscious bias. And there's a lot of different ways, but I'm going to focus on one way. Attitudes are associations between things and a valence, either positive or negative. So you can have either a positive or a negative attitude. And implicit attitudes or unconscious biases can be therefore assessed by measuring the strength of these associations between things and valence. Okay? Now, to help to introduce the idea of the implicit association test, which I'm going to talk about in a second, I want to give a thought exercise. If I gave you a deck of cards and I asked you to sort it into hearts and diamonds in one pile and spades and clubs in another pile, I presume that that would be fairly simple for people to do, right? Probably could do that fairly quickly. Now, what if I then said, okay, I'm going to change the rules. Now I want you to put hearts and spades in one pile and diamonds and clubs in another pile. How many people think that their performance the second time around would be slower? Okay, likely. Do we have any avid bridge players in the audience? Anybody likes to play bridge? Okay, if you play bridge, you might have said, well, I might be a little slower, but not too much because hearts and spades are high trump cards and diamonds and clubs are low trump cards, so they have an association. But the difference between the two sorts is really that association. Is there some kind of link between the two items that you're sorting in one pile versus the other? So that's why the colors really would help us to speed up our performance. So this idea is what's used in something called the implicit association test, which was developed by a group of researchers who are now at Harvard, and they host a website where you can go, and I would encourage you to do so, go and test implicit associations about lots of different things. And here I'm showing two of the ones, and these actually happen to be two that I've taken. The one in the upper left-hand corner is what they call the black-white IAT. And here what you have is an example of a trial in which you have a face, and you have to press either the left button or the right button to indicate if this is an African American or a European American. Okay, so in this case you would press the left button. And then other times you have words that are either good or bad, and you have to sort them to the left where it says good or to the right where it says bad. Okay? And one of the trials, African American and good are on the same side of the screen, and on the other set of trials, African American and bad are on the same side of the screen. And so what you do is you measure the speed at which you sort these faces and words based on whether African American and good are paired or African American and bad. And so if you find that you're slower to sort when African American and bad are on the same side of the screen, then you have a preference towards white or a preference against black. Okay? And then this one down here is slightly different. It's not just about valence. It's about association between men and women and either science or humanities. So here you're sorting words like mother, father, daughter, sister, brother, and engineering, literature, physics, humanities, etc., so that you are then having to sort either where science and male are on the same side of the screen or where science and female are on the same side of the screen. And I'll just let you know that I basically, what I would call, failed both of these tests. So I'm the head of the diversity committee. I consider myself to be very unprejudiced when it comes to race, and yet I had a moderate preference towards whites. Also, I am a female in science. My mother is a female scientist. I have lots of wonderful female scientific colleagues, and yet I also had a preference towards associating males with science. So in both of these cases, my thought ahead of time about what my attitudes were did not match with the results of this test, and it's very disconcerting. So I will warn you that this may also happen to you when you take these tests. But it's also revealing. One of the creators of this test says the IIT measures the thumbprint of culture on our minds. And so the thumbprint that the culture that I've been exposed to has left on my mind is one that's biased against blacks and against women in science. So when people take these tests online, thousands of people take them, they can then say, of the people that take the tests, who are mostly Americans, how prevalent are different types of unconscious bias? Well, it turns out that about 75% of all people who've taken the black-white IIT online show an implicit white preference. And in fact, 30% of the African Americans who take this test show an implicit white preference. One of the strongest implicit preferences is for young versus old. 80% of people show an implicit preference for young over old, and this is just as strong in older adults as it is in younger adults. Another IIT is the Gender Career IIT that looks at how quickly you associate women with work and women and men with work versus family. And on this one, 75% of the men who take it have a stronger association of male with work than female with family, and 80% of the women who take this have a stronger association of male with work and female with family. 76% of people show an implicit preference for able-bodied versus physically disabled. And interestingly, the correlation here between what you say you think your attitudes are and what actually is revealed on the test is the lowest for all the tests that they show. So these implicit or unconscious biases can be measured with these types of associations, and what we've been talking about so far is this idea of sort of positive versus negative valence. But some researchers, including Fisk and Cuddy, have been interested in the idea that there might be more than one dimension. That might not just be positive versus negative, but there might be two dimensions that are orthogonal, warmth and competence. And it turns out through a lot of research that different groups within the United States can be categorized on these dimensions of warmth and competence. And the idea here is that when you initially approach someone, you need to quickly figure out two things. Is this person going to be helpful to me? That's the warmth. Is this person interested in helping me? That's the warmth. And are they going to be able to help me? That's the competence. Okay, so the idea is that's where these things came up. And this chart shows how groups have traditionally been rated in the United States. So in terms of folks who are rated as low warmth and low competence, poor blacks and Latinos, and the types of emotions that tend to be associated with ratings of low warmth and low competence are disgust and contempt. Low warmth and high competence are groups like Asian immigrants, professional women, lesbians. And their evoked emotions here are envy and jealousy. High warmth, low competence groups are groups like the disabled, the elderly, and effeminate gay men. And those emotions that are evoked here are pity and sympathy. And high warmth, high competence in the US are middle-class whites and heterosexuals, and the evoked emotions here are pride and admiration. So it's important to see that there's some nuances to our automatic reactions as well, and it may determined the type of emotion that we feel towards somebody just right off the bat. Okay, so now we're going to do an exercise, and I'm going to have Dean Atchison come up and explain the exercise to you. And if I could have my helpers go ahead and start passing out the materials, please.
Okay, I apologize in advance. I don't think we have enough materials for everybody to get one, but please bear with us. So you should be getting a packet of 3 different documents. One is a CV and 2 letters of recommendation. And the scenario here is that you're evaluating an applicant for a generic sort of clinical research fellowship. So what we'd like you to do is take a few minutes to go ahead and review that material. And then on the back page, go ahead and make a rating from 0 to 10 on how acceptable you think this individual would be for the position. And when you're done, just fold it over and pass it to the end of the row.
Dean is 1 best or 10 best?
10 is best.
Okay.
Yeah, so the last page of this handout you can tear off, and that's where you're going to make your rating.
So now that everyone's made their rating, we're going to briefly have the committee members put you into groups. And what we'd like you to do is just briefly discuss how you came to your rating of that individual and come up with a group consensus rating. Please resist the urge to just average everybody's individual ratings and actually have a quick discussion about it, okay?
So find the other people that rated the same applicant as you.
Yes. You should all be grouped up already.
So you see both competence research is a little bit slower than
What about the fact that he went to University? We were discussing this. He said, what would happen if you...
There's a time we're going to move on, but yes, you're right. You all rated the exact same person. All we changed were the names and the pictures, right? And so Lisa's going to throw up your average and range of your individual ratings and then your consensus ratings, just so you can see that.
Okay, so Dr. Amy Burns in the individual ratings had a range of 5 to 8, and the mean was 6.8, and the consensus that the group came to then after discussion was 7.5. Sorry, 6.5. Sorry, you're right, 6.5. Sorry. Okay. So that's pretty close, actually. DeAndre Burton, the range of the individual scores was 4 to 9, with a mean of 6.4, and the consensus was 6. Maria Diaz, the range was 6 to 10, and with a mean of 7.8. And after discussion, it was 6.5. Ji-Hoon Park was 3 to 9, with a mean of 6.8. And after discussion was a 7. Vonda Jones was 5 to 9 with a mean of 6.8. After discussion was an 8. And Daniel Miller was 3 to 9 with a mean of 6.1, and after discussion was 5. Okay. Any thoughts about the numbers here? Anything that surprises you? Yes.
I think it's because we're in
Yeah. There is a comment over here.
I just think it's fascinating, and especially when we saw in our group, kind of how the average ratings of people in our group, at least, we didn't go around and say, I gave this person this, I gave this person this. We kind of all sat back and waited until the discussion started. We all kind of let it fly what we gave. And it's interesting to see the individual average rating and how it changed in each group. And I have a feeling it was driven by one or two people in each group. And at least in our case, I think our highest number someone that we all felt had more experience. And I think we kind of felt that. And I kind of wonder the ones that went the opposite way, where they had a much higher average than what they finally gave, and what pulled it down.
Right. So in a way, there was a little bit of an equaling out of these identical candidates with the group consensus. However, each individual group may have changed one way or the other, and perhaps that has to do with the influence of influential group members, which I think maybe brings up the point that you want to make sure to have a diverse group, but also make sure that each person gets a chance to and feels equally validated and valued so that they can each contribute equivalently. Another comment.
Yeah, it's interesting, these are all the same person, so we have some 3s up there and all the way up to 10. So I think maybe one issue is just that we're all coming from different places, like some of us are medical students and some of us have been faculty for a long time, so we have different understandings of what a good fellow should be. So like if I were a new person on a admission committee, I guess I don't really know what are the qualities of a typical successful fellow in our program, what have they been, and then we would kind of, say, let's shoot for, sort of applicants that seem to reflect what we typically have, let's make them an 8.
Yes.
Let's try to make those 8.
So it sounds like you would like some more criteria, a little bit less open-ended.
So I know that if someone gives them a rating like above 8, I know that this person exceeds our typical expectations.
Right.
Something like that.
Okay. Well, good. Well, I want to move on, and I hope that you'll continue thinking about this and also thinking about your own identity and your own potential biases and how they may have played a role in this exercise, and also how they may have played a role in how you interacted with your colleagues as you were discussing this. I think there's a lot of places in this exercise which we developed because it's one that we do a lot in this department. There's a lot of places where bias can play a role, and so I'd like you to just continue to reflect a little bit about this. Okay, so now the question is, I think we've talked a little bit about it. You've had some experience now with the idea of unconscious bias, but are there any research studies out there that suggest that unconscious bias makes a real difference? I hope you're sort of intuitively feeling like maybe it does, but I'd like to present a little bit of research suggesting that it does. If you were here in the beginning and you watched the slideshow, you saw data from this study already. People who are CEOs of American companies are taller than the average man in America, since most CEOs are men. They're taller than the average man in America, and you get a higher salary for every inch of height. Now, now you could say, and I think this is a good example of where unconscious bias is helpful, or where unconscious bias is playing a role, because it's pretty clear that people are not sitting in the boardroom going, we should get the tall guy. So clearly things are going on beneath the surface that are associating height with positive attributes, leadership skills, confidence, whatever it might be. And so there's clearly a role there. Another, as I mentioned, a strong unconscious bias that we have is towards youth, away from age. And as I said, this is shared by old and young people alike. And one study measured the effect of these automatic negative age biases and found that those who had the strongest automatic negative age bias lived 7.5 years less than people who had more positive automatic attitudes towards age. In the healthcare arena, something very relevant to what we do, there was a study that looked at how patients who were either had the same exact symptoms, kind of like the exercise we just did, same exact symptoms except for they were white versus black, and then doctors were asked to make recommendations about what should happen for these patients. And the degree to which, and prior to that, they had taken the black-white implicit IAT, and those who had the strongest implicit preference away from blacks were the least likely to recommend those black patients for thrombolysis. So it had kind of a real-world consequence in this particular study. And going back to that same meta-analysis that I mentioned before, that we're looking at the association between explicit judgments and attitudes and how people performed on tests of discrimination, they also looked at the influence of implicit attitudes. And what they found that for behaviors that had to do with, specifically with race, that the implicit bias strength was correlated with discriminatory behavior at a rate of 0.24. Okay, so you might say, well, 0.24, that's just a moderate effect size, it's not that big. But remember that the explicit judgments were correlated at 0.12. So this is twice the size of the effect, suggesting that it has a very real influence. Okay, now this is an interesting study where, to tell you about some particular types of unconscious bias, this was a study where radiologists were shown CT films, and they were asked to flip through these films and do a very typical thing that they do, which is count lung nodules. So that's, for those of you that aren't radiologists, that's these things here. And so you're supposed to go through and count them and write down how many lung nodules there were, and they were flipping through the CT scans very rapidly. And on the third time through, they introduced something into the CT scans. And after they were done counting the number of nodules, they asked the radiologists, did you see anything different about the third time through? And then they could say yes or no. And then they said, specifically, did you see the gorilla? Does anybody see the gorilla? It's up here. It's actually easier to see on my screen than it is on there. But there was a gorilla in every one of the CT images on the third series. 83% of the radiologists said they did not see the gorilla. They did not report seeing the gorilla, and they had eye tracking data to show that they had actually looked right at it, but they didn't report seeing it. And so this is what we call inattentional blindness. And again, it's a very adaptive thing. We have so many stimuli impinging on us at any one time that we can't possibly pay attention to all of them, so we focus our attention on the task at hand. So in this case, I'm not saying this was a bad thing. I would like the radiologist to be very focused on the number of nodules if it's my lung CT that they're looking at. But it just goes to show that the power of our things that are happening unconsciously, these stimuli are getting in, but they're not being recorded. Another type of bias that you should probably be aware of is diagnosis bias. This has to do with first impressions and the importance of first impressions. Oftentimes we have an automatic reaction to someone, and then that will carry forward, and it's very hard for us to take in contrary information after we've already formed an automatic opinion about someone. And the role of this was brought home by a study that showed that looking in Toronto at medical school students who were interviewing, and they classified those medical students into those that had been interviewed on a rainy day versus a sunny day. And actually, rainy day could have been sleet, hail, snow, whatever. It's just precipitation, bad weather, versus a sunny day. And they found that those that were interviewed on a rainy day had scores that were, on average, 1% lower than those that were interviewed on a sunny day. Of course, no correlation with any other factors except for the score, the rating. And you might think, well, 1%, that's just in the noise. But it turned out that when they did a regression showing factors that predict admission to medical school, a 1% lower score for the interview was equivalent to a 10% lower score on the MCAT. So it had, a small but real effect on whether these people were admitted. And then I'd like to then talk about a very pernicious and difficult type of bias. This is internalized bias and a related concept of stereotype threat. So, Woody Allen said, I'd never want to be a member of a club that would have me. And this is kind of this thing, which is that some of us have biases against the very groups that we're a part of, the very parts of our identity, and yet we have an implicit bias against those. Like, for example, my bias against women in science, even though I am a woman in science, or the 30% of African Americans who show a moderate bias towards whites, what a preference for whites. This kind of internalized bias can have big effects. Stereotype threat is related to this in that it's kind of a threat that your behavior is going to confirm a stereotype. And so an awareness and a heightened concern about your behavior relative to whether it's stereotypical or not. And it turns out that internalized bias is very sensitive to priming. And you can have activation of these internalized biases and stereotype threat that can really affect behavior. And I want to tell you about 2 studies. In one study, women and men were brought in and they viewed some commercials, just random commercials. But one group was also given 2 additional commercials that were intended to activate negative stereotypes about women. One of them portrayed a woman so excited about an acne product that she bounced with joy on her bed. And another one showed a female college student dreaming about becoming homecoming queen. When they saw these, women who saw these commercials were more likely than women who didn't to, on a subsequent unrelated task, they were asked to place themselves either in a leadership role or a subordinate role in a team study that they were going to do next. And women who saw the stereotype activating commercials were less likely to put themselves in a leadership role, more likely to put themselves in a subordinate role. Whereas those that didn't see these 2 commercials, men and women were equally likely to ask to be in the leadership role. There can also be competing internalized biases because, of course, we're all members of different groups. This one study was very interesting. It looked at Asian women. And in one version of the task, the ethnicity was primed by asking about the background and characteristics having to do with Asian identity, and then went on. And in the second group, it was about their gender identity. They were asked to say whether they were a man or woman, and also things about their gender. And then the second part of the test was a math test. And what happened was that Asian women who were primed about their Asianness performed better than other groups on the math test, but when they were primed about their being a woman, they performed worse on the math test. Okay, but you might still be saying, but I'm not biased. Everybody else has bias, but I'm in that 25% that's not biased. And that might be true. And I'm certainly not out there to say that everybody is biased about everything. I think it's a self-exploration. We have to figure it out. But I will just point out that on the black-white IAT, about 40% of respondents who took the test online report no explicit bias, but are shown to then have implicit automatic biases. So there's almost half of people have a dissociation between what they feel and how they actually perform on this implicit test. And as I said, this happened to me, so I know it's an unpleasant thing. They did a study of MDs in particular, and they found that the size of implicit race bias was about twice the size of explicit race bias in a group of physicians. And unfortunately, there's some costs to these hidden biases. Dissociation between your implicit and explicit attitudes leads to discomfort in you and also discomfort in patients, it turns out. Implicit attitudes tend to influence our nonverbal behaviors, whereas explicit attitudes influence our verbal behaviors. And so when you have a dissociation between the two, you may be saying one thing but doing another. And this kind of duplicitous kind of behavior is seen as untrustworthy and can be particularly difficult for people who have a history of looking for bias. So people who are in minority groups and are very alert to the possible presence of bias can recognize this dissociation very quickly and see people as untrustworthy. In fact, patients who were asked to rate their satisfaction with providers who had this kind of dissociation rated those providers as less satisfying than ones who had both negative implicit and explicit attitudes. So they were less satisfied with the people who had a disconnect between their implicit and explicit attitudes than even those people who were negative in both realms. And then I'd like to talk just a little bit about microadvantages and microinequities. When we practiced this workshop, we had a little bit more time. So unfortunately, I think we're not going to be able to have time to do the skit that we were going to show you, but I will describe a little bit about it to you, but I want to make sure that we get to the punchline. But microadvantages and microinequities are these kind of drop by drop. So up till now, I've been talking about how big decisions like hiring, promotion, how we react to people during an interview setting. But actually, unconscious bias has a lot of influences that are very small. They have to do with gestures, using a different kind of language, a different kind of treatment, even a tone of voice. And the cumulative effects of this can really advantage one group versus another. And the other important part is that there's only so many resources to go around. And so to the extent that you may be biased towards and show micro advantages towards one group, you are actually disadvantaging another group because there just isn't enough resources to go around. So it's something to be aware of. The skit that we were going to show you as Dr. Smith was going to be introducing her two postdocs to a clinical researcher. And what we're going to try to illustrate here is that Dr. Smith could have intentions to treat those two postdocs just the same, but by playing up shared characteristics with, say, her female postdoc and saying, oh, you both went to Stanford, she's doing some really excellent work, her research is very important, perhaps you could take a look at her K award. But then busy Dr. Jones is about to leave, and so all she gets to say about poor male postdoc is that he's a really good technician and it's a really great thing that he's in the lab, and she's about to talk about his research when Dr. Jones walks away. Okay, so this kind of thing I think happens a lot where we don't even intend to treat people unequally, but just subtle things can give slight advantages to one person over another. And I think we should all think about the role of unconscious bias and how it impacts different relationships in academic medicine, faculty to trainee, doctor to patient, faculty to faculty, administrator to faculty, researcher to participant, institution community. So be aware of these interactions and how to deal with them. So the question is, how can we minimize negative consequences of unconscious bias? It's been said that to know what we do not know is the beginning of wisdom. So hopefully the beginning of wisdom about unconscious bias has started today because we know more about it now and we understand a little bit about what effects it can have. But I'd like to emphasize that we can't and we probably shouldn't attempt to just eliminate bias or suppress it. Research has showed that, in fact, if you try to sort of suppress these types of automatic reactions, paradoxically, they get activated and your behavior is worse. So suppression is not the way to go, but what are some of the ways that we could address this? Well, the first thing is to shine a flashlight on yourself. You need to practice what we call constructive uncertainty. Think about the situations where you have a strong reaction one way or the other towards somebody, strong positive gut feeling, a strong negative gut feeling. Shine a flashlight on that. Where might this be coming from? What about that person reminded me of something in my past? What about that person is the same or different from me? Why am I having this reaction? Constructive means you don't want to get paralysis by analysis, right? You have to, you want to make sure that you're doing this when you have the time and when you have the opportunity. We can't, again, we don't want to eliminate automatic biases because they can be helpful to us to help get us through the day quickly. But practicing constructive uncertainty is something that we can practice and we can build our skills in this area. Individuation is very important. We do talk about cultural competence, and it's great to learn about other groups and understand generalities. But of course, every person is an individual. And what's important in terms of combating your general negative stereotypes about groups is to show yourself how different individuals are similar and different from those group norms. Okay, take your time. This really can't be emphasized enough. These automatic biases happen rapidly. They are quick processing. They are happening without the advantage of our highly developed frontal lobes. The more time we take, the more ability we have to then bring those self-reflective processes to bear and examine whether our decisions are the ones, whether our decisions should be guided by that initial reaction or not. Another important strategy for trying to minimize the effects of implicit bias are to expose yourself to what we call counter-stereotype imaging. So think if you realize that you have a bias that comes from your cultural experience, seek out counter-examples to that bias. Make them obvious to you. One of the researchers, Dr. Banaji, that has done the implicit association test, made herself a screensaver of counter-stereotype examples after she failed the black-white IAT. So she made herself a screensaver that flashes images of warm and competent African Americans and other groups that are counter to the implicit stereotypes that she found that she has. Another thing that's important is perspective taking, putting yourself in somebody else's shoes. When you have a situation where you are puzzled by why somebody behaved a certain way, think about what you know about that person's background, context, culture, individual experiences, how you've seen them behave in the past. Put yourself in that person's shoes and think, okay, if I had that set of context, what might my biases be, and therefore how might I have reacted? Would I have reacted the same? Engage with those that you see as others. This is actually sounds really simple, but it's probably one of the hardest ones. Okay, it takes courage to move out of our comfort zone. We talked about in-group versus out-group. It's very comfortable to be with people that are like us. We like being with people who are like us. And so to the extent that you can be courageous and take a step towards people who are not like you and do so with an attitude of humility and curiosity and ask a lot of questions and get to know other people that are not like you, the more you'll expand your range of experiences and help to kind of make a dent on that thumbprint of culture that's in your mind. It's important to also encourage feedback. Okay, we need to let each other know, and hopefully now that we've shared this experience, we can let each other know, I think I might have been negatively influenced by what that person said because it's so different from what my perspective is. Did you have the same experience? Encourage feedback. Ask people, it seemed like you didn't appreciate what I just said. Tell me more about that. Let me know what it is that I'm not understanding about your background. That kind of feedback is really important. Look out for opportunities for these micro advantages and micro inequities and think about them. One researcher realized that by giving to her Ivy League institution every year, she was giving micro advantages to groups that already had a lot of advantages. And so she decided that she would, in addition to giving a donation to her Ivy League institution every year, she would also donate to the United Negro College Fund, same amount. Okay, that was her attempt to equalize the advantages that she was trying to confer. And then take responsibility for unintended negative consequences of unconscious bias. Guilt is not helpful, responsibility is helpful. Let people know, this is something I'm working on. I realize I don't think I approached that the way that I had hoped to. So, for example, if I had, after we got back from the conference, if I had realized that I gave short shrift to my male postdoc, I could have gone on to him and said, I wasn't really happy with how that introduction with Dr. Jones went. I'd appreciate if you could, tell me more about how that felt for you, check it out with this person, and say, I'd really like to make it up for you, so I'm going to send an email to Dr. Jones, and I'm going to send her your latest paper and see if she has some comments on that. And take responsibility and try to make up for any mistakes that you might make, because we will make mistakes, because this is how we're programmed, and it's really hard to get rid of implicit bias. In fact, it's so hard to get rid of implicit bias that, unfortunately, this is an area that hasn't been studied all that much. How do we get rid of implicit bias? All those suggestions, you can find them all over books and things like that, but are any of them really evidence-based? As far as I can tell, this is the only study that's tried to do an intervention to reduce specifically implicit bias, and they talked about this as a habit-breaking intervention. And what they did is they had a multifaceted approach where they made everyone aware of their bias by taking the IAT, gave them education about it, and then training on some of the things that I just talked to you about: stereotype replacement, counter-stereotype imaging, individuation, perspective taking, and increased opportunities for contact. And they did this in a 45-minute session, and then they sent the people away, and then they brought them back periodically and tested both their implicit and explicit attitudes towards race. And what you can see here is that those who had been in the 45-minute intervention 4 weeks later and even 8 weeks later had lower implicit bias, whereas those that had not been in the intervention were back to their baseline level. So you can see here that there's not a significant difference at week 8 at this point because of what's happening in the control group. But this is the beginning of trying to understand what strategies are the most effective. But I think if you follow some of the ones that we have, it'll be helpful. And there's, of course, institutional strategies as well. I'm going to skip over this in the interest of time because I want to give you a chance to consolidate it. There is, on the back of your blue handout, there is an action plan. It's about the the second page in your thing. And what I'd like you to do is real quickly just jot down one short-range goal for this week that you can do to try to minimize the impact of negative impact of implicit bias, one medium-range goal and one long-range goal. And if you need some help, right behind that is a handout that we have for you to take home with some strategies. So maybe you can just borrow one of those and put it there for your goals. And then I know we're over time, so if you have to go right now, please also let us know how we did. There's an outcomes evaluation survey where you rate sort of how your knowledge and intentions changed. If you could quickly fill that out, and then also the CE evaluation. This is our general evaluation of the program that we need for CE credits. And please let us know anything we should do differently, because we will be doing this program again for other trainees and for other faculty members, and we really like your input about that. So thank you very, very much for your attention.
Before we go, I'd like to thank Lisa and the group for all their efforts